On to our next speaker, Dr. Ronnie George, a senior glaucoma consultant from Medical Research Foundation, a great national and international presence and repute with innumerable awards and accolades. And he's going to talk to us on a very quintessential topic, from clinical trials to clinical practice. We look forward to hearing from you, Doctor. You are muted. Can you unmute yourself?
Ronnie, you are muted.
Why is it he's... Okay, okay, right.
Yeah, can you hear me now?
Yes.
Yeah. Yes.
Yeah, so I'm sorry. Thank you for the kind invitation, and I'm going to try and cover some of the clinical trials and how I'm using them in practice today. I'll start with the ocular hypertension treatment study and the early manifest glaucoma and the EGPS study. So basically, if you look at the ocular hypertension treatment study, we did notice that intraocular pressure reduction prevented progression in ocular hypertensives. And what we realized is that if you treat 16 people for 5 years, we can prevent 1 progression. But what you also look at in the study is that 90% did not progress even without treatment. 40% of those who were on treatment required more than 1 medication to reach a 20% intraocular pressure reduction, and 9% required 3 or more drugs. So none developed sight-threatening field loss. So because of this, we can consider monitoring most ocular hypertensive patients even after risk assessment. And when you look at risk assessment, both the ocular hypertension treatment study, which showed that the group with the highest intraocular pressures and the lowest central corneal thicknesses, and the European glaucoma prevention study showed the same risk factors, that this group, the group with the thinnest corneas and the highest intraocular pressures, were at the greatest risk of progression. And if you apply the same number needed to treat calculation here, you find that you can reduce the NNT to 6 by just treating those at highest risk for progression. So that's something that we have applied in our practice very commonly in trying to decide who to treat among the ocular hypertensives. The other thing that came out of the ocular hypertension treatment studies, when they looked at progression, when they looked at both the medication and the observation group, the majority of people showed progression on the optic disc alone. And this has got more evidence of late that more disc changes occurred early in disease, and perhaps we should pay attention to structural change in addition to functional change in these patients. Moving now to people with manifest glaucoma, the early manifest glaucoma study basically looked at treatment versus no treatment for people with established disease. And here too, you saw a significant reduction in progression in people who were treated for established glaucoma versus untreated. And from the EMGT, we realized that patients should be followed up more closely with visual fields during the first few years after diagnosis, because progression may occur in half of your patients even after you have reduced IOP by 25%. So the EMGT, the concerns that we had basically was the treatment was probably inadequate because they had a combination of trabeculoplasty and betoxolol. Unfortunately, in the last decade, we had the UK GTS, which looked at latanoprost versus a placebo in these patients. And look at this thing in the study design that they have. They planned for 16 fields over 24 months. And the majority of their patients actually had IOPs less than 21. Even in this group, they noticed that patients who were started on treatment did progress much less slowly than patients who were not started on treatment. And in both these studies, what you saw was visual field progression was much more commonly seen than optic disc progression. In fact, if you look at this is again from the UK GTS study. At approximately 3 to 6 months, you started to be able to detect visual field progression because you did intensive visual field testing. And this effect slowly increased over time. So if you do adequate visual field testing, you can even start to see progression as early as 3 months into the post-disease detection. What about once you have had established glaucoma? And here you have the AGIS study, and the advanced glaucoma intervention study basically looked at intraocular pressure in 2 ways. One is a predictive analysis, which looked at the average intraocular pressure over the first 6-month visits, and the associative analysis, which looked at the percentage of visits with an intraocular pressure of less than 18 millimeters of mercury. And what you notice over here is, for the predictive analysis, that is of the first 3 visits, if you had lower mean IOPs in the first 3 visits, you were much less likely to progress. For the associative analysis, which is an IOP of less than 18 millimeters over 60 years, you could see that as the mean IOP was less, you were much less likely to progress. So from this, you have basically 2 points. One is intraocular pressure reduces visual field progression. We know that there may be a dose-response relationship in the sense that the lower the IOP, the less risk of visual field progression. And fluctuation is an important part of the damaging effect of intraocular pressure. So it's important not only to reduce IOP adequately, but also to minimize fluctuation. Switching gears a little bit now to the TVT study, and this is the first TVT study, and basically they concluded that tube shunt had a higher success rate compared to trabeculectomy during 5 years of follow-up. But both procedures had similar IOP reduction and use of supplemental therapy at 5 years, and that additional glaucoma surgery was needed more frequently after trabeculectomy with mitomycin than tube shunt placement. But the concerns with this study were basically their inclusion criteria, because they did include patients who had a previous failed trabeculectomy. And we know that eyes that have failed a trabeculectomy once are more likely to fail it again. And therefore, this could have biased the results significantly. And therefore, they did not really change our treatment pattern too much after seeing the results of this study. And we were basically fortunate that soon after that, we had the primary TVT study, which showed you that the trabeculectomy actually did better than the tube group, in addition to having lower intraocular pressure levels, at least at the 1 year, and even the 3-year data is similar. Switching to the LIGHT study, which came out recently, which looked at the SLT versus eye drops as first-line treatment for ocular hypertension and glaucoma. At 36 months, more than 95% of eyes were at target intraocular pressure in both groups. And here the target IOP was calculated individually for each patient. What's interesting here is that 75% of eyes maintained target IOP with one SLT treatment over 3 years, and about 68% of eyes were controlled adequately with one single eye drop in the medication group. So SLT is a valid primary treatment for primary glaucoma. It also shows that a lot of our patients, we may be able to achieve fairly good IOP control with some of the newer medications available to us, and we may not need to escalate that frequently. But what was also new here was that the group in SLT also required as much follow-up as a group on medication, so that does not come down. Moving now to the angle closure disease, and here you have the EAGLE study, which was basically a randomized controlled trial which looked at the early lens extraction for the treatment of primary angle closure glaucoma. They had patients who were with primary angle closure glaucoma who basically had an IOP of more than 21 at least once, and you also had patients with primary angle closure who had at least one IOP of more than 30 millimeters of mercury. And on the angle, they had more than 180 degrees of apposition or synechial closure. In their results, which was primarily looking at quality of life, they found slightly better quality of life. I'm going to keep that aside. And they found slightly lower intraocular pressure in the clear lens extraction group of about minus 1.2 millimeters of mercury. I'm going to show you this plot here, and I want you to focus on the right side of the screen. And here I have circled these factors. And what I want you to look at is here. If you look at the non-Chinese ethnicity, you find that the intraocular pressure actually was not significantly different between the groups. If you look at primary angle closure, again, you find that the intraocular pressure was not significantly different between the groups. And if you look at the visual acuity on the left side of the chart, you find that it was not significant in patients who had better than 85 ETDRS letters in terms of quality of life. So what basically happened is people who had a little bit of cataract, the cataract extraction improved the quality of life. But in terms of the IOP reductions were actually not really uniform and were pretty small. It was just about 1.2 millimeters of mercury. And it did not answer my biggest questions on the role of clear lens extraction, basically what happened to the angle. There was a lot of missing data at the final visit, and therefore you cannot make any conclusions about what happened to the angle. Intraocular pressure differences were just about 1 millimeters of mercury, and there was no real disc or field changes. So the EAGLE study did not really change my clinical practice, and I have not really incorporated its findings into practice. So to summarize, for ocular hypertension, titrate risk, look for structural damage. For early glaucoma, do adequate visual field testing, and both medications and SLT may be effective in achieving this. For established POIG, aim for lower intraocular pressure and minimize fluctuation if you can. Trabeculectomy is still my first choice for primary surgery, and clear lens extraction, in my opinion, there's inadequate evidence to suggest its use. Thank you.
That was a lovely talk and a very good summary. But I have this question. Are the advanced glaucoma intervention recommendations still valid? That is less than 18 millimeter mercury in all visits and majority in less than 14. Would you try to keep the IOP in that range, or would you look at it keeping it lower after what we understand more today?
No, I think it needs to be kept. I mean, this is just, these are just averages. So basically, when you look at less than 18, you still had progression. The no progression was seen in the less than 12 group. And I think one thing that we should remember is that even though it was called the Advanced Glaucoma Intervention Study, there were not really all that patients with really advanced glaucoma the way that we see in India. So those patients, maybe we would aim for a lower target intraocular pressure, but otherwise it's better to go with an individual target intraocular pressure for every patient based on their presenting intraocular pressure and the amount of damage, rather than using a uniform cutoff of 18 or 12 or 14.
Murli? Murli, you're muted. Unmute yourself.
So would you use risk calculators in deciding whether an ocular hypertension patient needs treatment or not, or observation? How valuable are these risk calculators?
See, the risk calculator is an easy way of demonstrating to the patient what the risk is. The only issue with the risk calculator there is the diabetes, because the diabetes was actually protective in the ocular hypertension treatment study. So that's the only concern I have. Otherwise, the risk factor is a good way of telling the patient what the risks are. But keep in mind that Indian corneal thicknesses are not the same as the Western corneal thicknesses. Our corneal thicknesses are a little lower by maybe about 20 microns or so. So you don't extrapolate the actual values, but you can extrapolate the risk factors.
Murli, you have one more question before we go on to our the next talk?
Yes. So what I wanted to ask was, are the findings of the CGIT study, initial glaucoma treatment study, valid in the Indian scenario? Does it guide us as to what we need to choose as our initial treatment for a glaucoma patient?
I didn't put it in the interest of time. So basically, when you look at the CGIT study, both medication and surgery did equally well. But surgery was complicated by poorer quality of life values, mostly because a majority of patients developed a cataract. And again, the study was done some time back. So I'm sure with the newer medications and the better surgical techniques that we have today, I don't know whether the same would hold true even now.
Yes, very true. That was a great talk, Dr. Rodi. Stay with us. We'll go on to the next session.